Welcome to the Deep Dive. Today we are plunging into, well, one of the most controversial and misunderstood topics in modern mental health.
Yeah.
Uncontrollable sexual urges.
It really is. I mean, just the act of trying to name this condition is a huge debate in itself.
Exactly. Because the underlying argument, is this a moral failure? Is it an addiction, a hormonal thing, or maybe a response to deep trauma? That question has basically split the entire psychiatric community.
It has. And the stakes are so high because the model you choose, the label you use, it dictates the treatment you're going to offer. We're talking about terms like hypersexuality, sexual addiction, and the one that's now the clinical frontrunner, compulsive sexual behavior disorder.
Or CSBD.
Right, CSBD. Our goal today is to cut through all that noise and guide you through the science, the neurobiology, the trauma theory, the pharmaceutical side of it, to really understand what might be driving this.
And the sources we've pulled together for this are high-level clinical papers, major psychological reviews, and the diagnostic guidelines that are literally reshaping global psychiatry. So our mission here is to give you a clear map of these competing ideas and explain this major diagnostic shift that's happened.
It's a big one.
Okay, let's unpack this.
Yep.
So let's start right there with the terminology. What do we even call this?
Well, historically, the language has been completely dismissive. If you look back, you see terms like nymphomania or satyresis.
Right, and those are so loaded with moral judgment.
Tremendous moral weight, and even a more recent term, hypersexuality, is pretty controversial. A lot of modern clinicians argue that just calling a high frequency of sexual behavior a disorder might just reflect our own cultural discomfort, especially in more conservative societies. It's not necessarily a clinical dysfunction.
That distinction, cultural distaste versus actual clinical dysfunction, that's the whole battlefield, isn't it?
It is.
I mean, if someone just has a high drive, that's not a pathology.
Yeah.
So how does the modern clinical world actually draw that line?
So they've drawn the line with this term, compulsive sexual behavior disorder, or CSBD.
CSBD.
Right. And this is really the key piece of information for our whole discussion. The World Health Organization, through the ICD-11, officially classified it back in 2018.
And what did they classify it as? Because that's the big debate, right? Addiction or something else.
Exactly. And they made a really crucial decision. They categorized it as an impulse control disorder.
So like pathological gambling.
Precisely. And in doing that, they explicitly rejected that whole sexual addiction framework that had become so popular, outside of formal medicine.
Wow. That reframing is huge. So it shifts the focus away from a kind of substance analogy where you want to have withdrawal to the basic function of impulse regulation.
That's it. It's about the failure to control the urge. It doesn't really matter what the target of that urge is.
So what are the criteria then?
The ICD-11 requires a persistent pattern, so we're talking at least 6 months, where the person fails to control these intense, repetitive sexual impulses. And this leads to behavior that causes marked distress or, significant impairment in their life.
Like losing relationships or their job.
Exactly. Losing a job, relationships, getting into financial trouble. But, and this is the key check, the ICD-11 explicitly says that distress based solely on moral or religious judgments is not enough for a diagnosis.
Okay, so if someone is perfectly happy with their high sex drive, but their community shames them for it, that's not CSBD.
Correct. It's a massive step toward clinical objectivity. The disorder is in the loss of internal control and the functional impairment that follows.
What's so fascinating, though, is how divided the global community still is. The American system, the DSM-5, it famously rejected all proposals for hypersexual disorder or sexual addiction.
It did. It left no standalone diagnosis for this pattern in the U.S. manual at all. So you have clinicians globally operating under two completely different frameworks.
But the need for treatment is still there. I saw the global prevalence is estimated to be around 5% of the population who might be at high risk for CSBD.
Which makes it a significant public health issue, regardless of the label.
And before we move on, we have to quickly mention a condition that gets confused with this all the time, but is totally different. Persistent genital arousal disorder, PGAD.
Yes, a vital distinction to make. PGAD is rare. It mostly affects women, and it involves this unwanted chronic genital arousal. But the key difference is it happens without any sexual desire.
So it's a physical thing, not a psychological urge.
Exactly. It's often linked to neurological issues like nerve compression from Tarlov cysts, or even sometimes triggered by withdrawing from certain SSRIs. The symptoms are physical throbbing, burning, not driven by an intense impulse. CSBD is all about the impulse.
Okay, here's where it gets for me, really interesting. Let's shift gears to the psychological model, which just completely reinterprets the cause. Instead of a lack of control, they're talking about survival.
It's such a powerful pivot. A lot of trauma-informed researchers view this behavior not as a vice, but as a, quote, biography of survival told in the language of urgency.
Biography of survival. Wow.
And the research is consistent. Childhood trauma, chronic fear, neglect, severe criticism, it doesn't just correlate with hypersexuality later on, it structurally changes the brain.
How does it physically do that? How does it rewrite the brain's regulation?
It sensitizes the amygdala, which is our brain's threat detector. So if you grow up constantly on high alert, your nervous system is just chronically dysregulated. It's always looking for fast-acting relief.
And intense sexual experience provides that.
It provides this powerful, overwhelming rush. It basically acts as an emergency brake for a nervous system that never learned to settle. It's a rapid onset, self-administered sedative, and that's why it becomes so compulsive.
So the behavior isn't really about seeking pleasure. It's about frantically trying to regulate and avoid these intolerable feelings.
It's an adaptation. It's a messy solution to a really devastating internal problem. And this brings us to this important psychological idea in the sources, sexual narcissism.
I saw this described as the psychic middle manager. How does that fit in?
Okay, so if trauma deforms the core self, making you feel, unworthy or invisible, the adult needs a kind of compensatory structure, an armor.
Right.
Sexual narcissism provides this sort of glossy, erotic veneer of grandiosity and measurable validation. You seek control and affirmation through sexual conquest because your core self just feels shattered.
So there's the sequence. Trauma happens, the core self feels empty. This armor of sexual narcissism is built to find external validation, and then hypersexuality is just the behavioral performance of that.
You've summed it up perfectly. And what's also really interesting is the research noted that in religious participants, scores for both sexual narcissism and hypersexuality were often higher.
So repression and shame don't stop it.
They can make it more volatile. It turns a necessary adaptation into this deeply shame-filled secret.
That just changes everything for treatment. If the root is trauma, how do you even approach that? You mentioned bottom-up trauma approaches. For people who don't know, what does that look like?
Well, if the problem is seated in a dysregulated nervous system, in the body's alarm system, then traditional talk therapy, a top-down approach, often isn't enough.
Okay.
Somatic work is bottom-up. It helps the body complete defensive responses that were frozen by trauma. It might involve focusing on breath, movement, sensation to gently increase your tolerance for uncomfortable feelings. It helps the nervous system learn to settle on its own.
Without needing that emergency brake.
Exactly. It reframes the person not as someone who needs to be punished, but as someone who needs a new internal regulator.
Okay, let's pivot now to the purely physical mechanics. How do hormones and brain chemistry drive this system separate from trauma?
The biological models focus mainly on the mesocortical limbic system. That's our primary dopamine reward pathway.
The wanting system.
The wanting system. And we see evidence that sex hormones, especially testosterone and its precursor DHEA, play a massive role here. For instance, during the manic phase of bipolar disorder, increased sex hormones are very closely linked to hypersexuality.
How does that work chemically?
Testosterone acts on receptors that both increase dopamine synthesis and inhibit its reabsorption. So it's giving that pathway a constant chemical push.
Which provides a really surprising treatment hypothesis from the sources involving drugs most people would never connect to this. 5-alpha reductase inhibitors, like finasteride.
The hair loss drug.
Yeah, for male pattern baldness.
It's where the biological insight gets really practical. These drugs reduce dihydrotestosterone, or DHT, and the sources point out that DHT is the only independent hormonal predictor of orgasm frequency.
So reducing it would obviously have an impact.
A huge impact. But critically, these 5AR inhibitors also have a significant effect on reducing D1 and D3 dopamine receptors. So the benefit isn't just hormonal, it's directly hitting the neurotransmitters.
So it's a dual action thing. It's dampening both the testosterone pathway and the dopamine response. And the evidence, it's preliminary, but the case reports are pretty compelling.
They are. There's the case of an 86-year-old man whose intractable, disruptive sexual behavior just wasn't responding to anything else. And it was completely and successfully treated with finasteride.
And there was another one, a case series, that showed inappropriate sexual behaviors just disappeared in 6 out of 11 men after only 8 weeks on finasteride.
That kind of response is remarkable. It suggests at least a subset of these behaviors is highly responsive to this chemical approach. But again, these are preliminary reports. We absolutely need controlled, double-blind trials.
Okay, let's transition now to cases where hypersexuality isn't the main event, but a symptom of something else going on neurologically.
Right, and this helps us see the pure biological drivers even more clearly. CSBD has a very high comorbidity rate with mood disorders. Like we mentioned, it frequently appears during mania and bipolar disorder.
It's even a precursor symptom sometimes, right?
In 17% of patients, yes. It's a prodromal symptom before the first manic episode. We also see a high link with ADHD, which makes sense given the shared deficits in self-regulation.
But the most dramatic example, the real biological smoking gun, comes from patients with Parkinson's disease.
The Parkinson's link is one of the clearest demonstrations of dopamine's role you could ask for. Dopamine agonists, the drugs used to treat PD, are notorious for triggering impulse control disorders.
Gambling, compulsive shopping.
And hypersexuality. It happens because the medication pathologically activates that mesolimbic wanting system.
And the sources give this incredible pharmacological detail that pinpoints the exact receptor. It involves two different drugs, pramipexole and ropinirole.
This case study is fantastic. It's a 73-year-old male PD patient. He developed extreme disruptive sexual desire, we're talking public indecent exposure, after starting on pramipexole.
Okay.
But, and this is the key, when the pramipexole was stopped and he was switched to ropinirole, the symptoms completely remitted.
Go on. So why did that switch work? What's the chemical difference?
Pramipexole has a 5 to 7 times greater affinity for the D3 receptor subtype.
The D3.
Ropinirole, on the other hand, has the highest affinity for the D2 receptor subtype.
Okay, so if I'm tracking this, the D3 receptor is essentially the turbo boost button for this kind of compulsive reward seeking.
That's a perfect way to put it. It means the drive, at least in this context, seems to be heavily mediated by the pathological activation of that D3 pathway. It's a beautiful, clear insight into the neurological switch.
So if we step back, having looked at all this, trauma, hormones, specific receptors, what's the reality for treatment right now? Since no drug is FDA approved for CSBD, what are clinicians actually doing?
Well, treatment is very holistic. But off-label pharmacology is usually reserved for moderate to severe cases. A common approach is using SSRIs.
Antidepressants.
Right. And they're thought to work in one of two ways. Either through an anti-obsessive effect, which dampens the compulsive thoughts, or just through their common side effect of reducing libido.
Which mechanically gets in the way of the behavior.
Exactly. We also see naltrexone being used, which is typically for substance use disorders.
How does that work here?
It's an opioid antagonist. It seems to reduce the subjective, rewarding feeling of the compulsive activity, much like it does for pathological gambling. One double-blind trial found both naltrexone and an SSRI were significantly more effective than a placebo.
But for you listening and trying to figure out how certain this all is, what are the big limitations in the current research?
The gaps are substantial. First, most of this data comes from case reports or very small studies. Second, almost all of it relies on patient self-report,
which can be really biased by shame or other factors.
Highly susceptible to bias. And third, and this is critical, who is being studied?
Right.
The research is massively, overwhelmingly skewed toward heterosexual Western men. This leaves huge blind spots for women, for the LGBTQ+ community, for different cultural groups. We just don't have good data there.
That's a huge problem. But there's one last detail in the research about clinical failure that I thought was really powerful.
The issue of sexual function. Clinicians often just lack training in sexual medicine. The studies show that people with CSBD often have underlying sexual health issues, premature ejaculation, erectile dysfunction, that were there before the compulsive behavior started.
So if treatment is only about stopping the bad behavior,
you leave the person without the ability to have a healthy, satisfying sexual connection, which just sets them up for relapse.
So the goal can't just be prohibition. It has to be about achieving sexual health and well-being.
Absolutely. It's about gently softening that narcissistic armor, using bottom-up trauma work, and ensuring the person can experience genuine, functional intimacy.
So we've seen today that this is just an incredibly complex picture, rooted in trauma, brain chemistry, and sometimes other disorders. It is so far from the simple moral failing it's often made out to be.
And that ongoing debate, addiction versus impulse control, it continues because the mechanisms are so different from person to person. For some, it might be a D3 receptor issue. For others, it's intensive trauma work. But at its core, the behavior is often a costly, messy, but understandable adaptation to deeper wounds.
And to wrap up, let's go back to that ICD-11 rule. That distress based only on moral judgment isn't enough for a diagnosis. If this behavior is lost in the brain just desperately trying to outpace trauma or regulate itself, what is the true societal cost of responding with shame instead of treating the underlying wound? The ultimate goal, as the research suggests, isn't just stopping something, it's achieving genuine well-being. And that's something we're thinking about.
A really important point.
So consider that distinction between a high sex drive and true clinical dysfunction the next time you encounter this topic out in the world. Thank you for joining us for the deep dive.